Hello, and welcome to Visionary Medicine, the next era of retinal disease treatment and patient adherence. I'm your moderator, Rachel Deere with DKB Med. Thank you so much for joining us. And I'd like to welcome our esteemed faculty, Dr. John Kitchens from Retina Associates of Kentucky Eye Care Partners, and Dr. Joseph Coney from Retina Associates of Cleveland and Case Western Reserve University. Thank you both so much for being here.
Thanks for having us.
Thanks for having me.
And here are our faculty disclosures. This activity is supported by educational grants from Genentech and Regeneron Pharmaceuticals. All activity content and materials have been developed solely by the planning committee members and faculty presenters. This accredited activity is jointly provided by Partners for Advancing Clinical Education, or Partners, and DKB Med. Partners designates this enduring activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. In support of improving patient care, this activity has been planned and implemented by Partners for Advancing Clinical Education, Partners, and DKB Med. Partners is jointly accredited by the Accreditation Council for Continuing Medical Education, ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. And here are our learning objectives. Discuss consequences of delayed or interrupted treatment for neovascular AMD, and describe the efficacy and safety of newer anti-VEGF treatments for neovascular AMD. And now I'll turn things over to Dr. Kitchens.
Joe, it's always a great pleasure to be with you. I always learn something every time I do anything with you. And that's saying a lot because we do a lot of stuff together.
John, listen, it's always a pleasure, and I'm looking forward to a great discussion tonight on therapies and some of the burdens that we have with neovascular AMD.
Absolutely. And just a reminder, this is one of a three-part series covering the burden of disease for diabetic macular edema, retinal vein occlusions, and this one's going to be on neovascular AMD. So, Joe, I would like to start off with us actually hearing from some of our patients. And in fact, one of these is my patient, Melissa. She's one of my favorite patients. And we also have Anne. Both of these are patients who are receiving treatments for neovascular AMD.
Even though I know what's happening, still it's scary seeing somebody put a needle in your eye.
The day of the injections, afterwards, I usually come home and take a nap. I don't feel that great. And I will have soreness for a day or two.
It's kind of scary having the shots, but at the end of the day, it really helps. It gives me hope.
I missed an appointment when I had COVID, and that was distressing. I mean, it's always a little bit of, there's anxiety when the appointment's coming up, but I would say that I was more distressed when I had to miss an injection. But luckily I was able to get in not too long after that.
I've missed some appointments when I was sick, but we can see the setback, so I try to make sure that I stay healthy and meet every one of my appointments.
I would not be able to drive myself. I don't really see well after the injection. So, again, I'm fortunate. My husband drives me.
For me to meet my appointments all the time, I have to put my life around the shot. It comes first. Family and everything comes second. I have to miss a lot of things. I'm not able to go to some functions and stuff. So, but at the end of the day, your eyesight to me is very important. It's gradually over time, it's got a lot better. I'm 50% have my eyesight back. I have hopeful that eventually I'll have it all. But it's improving each time I get shots, a little bit at a time.
So, Joe, I'll tell you, Melissa and Anne are very frequent stories. I hear it from Melissa because she is my patient, but Ann's story is so familiar. Just that burden of treatment, that burden of disease.
John, unfortunately, these are stories that we deal with every day. And as healthcare providers, I think we really should be more in tune about the patient's journey. Just today, I had a couple of people that was late for their appointments by a couple of weeks, and because they often rely on other people to bring them in. The children sometimes are fear that they will lose wages. Sometimes I think that's a big problem. That as the patient gets older, they do rely on others because of transportation issues. But the anxiety piece is really real. I have this one patient; she loses like 4 to 5 pounds every week before she comes in to see me because she said that she cannot eat. And so to understand how this affects some people, I think really speaks to the burden of therapy, the burden of the time it takes patients to come to our office. I am aware that when they just come see me for an injection, it's not the hour and a half there with me. It's really, the day before, the day of, after the injection. And so all this stuff we have to be familiar with and understand their journey so we can make it as pleasurable as we can.
You're right. That anxiety is always there. And we do these shots sometimes 30, 40, 50 a day. And so it becomes so routine for us. And we're so busy that it's hard to stop and take time out and acknowledge that. What are some things that you do, Joe, in your practice to try and identify those patients who have anxiety and then to, as efficiently as possible, deal with that patient?
Well, I think on that first encounter is really important to help them to understand what it's going to be following that injection. And so we try to walk them through. We do a little more hand holding that first injection. We have a phenomenal staff. I think the staff really does most of the work while I'm going to see other patients and they're prepping the patient. They're getting them just prepared. So when I come in, at least the anxiety levels are actually much lower. But there's still several people that are going to have anxiety no matter what, whether it's from the injection, whether it's from the speculum, whether it's from the cleaning solution, whether it's how they feel after the procedure. And so it's always important to follow up with them to ask them how was the injection, and you can target some of the things that they have anxieties with. So if a person tells me that the worst part of the injection was a speculum, then sometimes I won't use a speculum for that patient.
Wow, so you actually customize your injections and your protocols for that patient. That's incredibly responsive, Joe. I think sometimes just that kind of sense of that patient's got something weighing on them. And instead of coming in and just, immediately going to the injection, asking, how are you doing? And if the patient pauses and starts to really get into things, stop and lean back, or sit down and cross your arms. If the patient's laid back, sit them back up. And all of those things just demonstrate the fact that you've got time to hear them out. And it takes a couple minutes, but it makes a huge difference for that patient. And they'll oftentimes apologize and say, I know you're really busy, but can you just answer a couple of questions? And just taking time out to realize, hey, listen, I might be behind, but this patient needs me right now. And let me take time to answer those questions and acknowledge this patient's concerns. And sometimes they're dry eye questions, but just stopping and pausing to do that makes a huge difference.
Absolutely, absolutely.
So Joe, listen, we talk about the burden of disease on patients. There's a big burden of disease in general. If we look at the global incidence of the main two things that we take care of, diabetic retinopathy and age-related macular degeneration, we can see that we are fairly overwhelmed right now. I mean, it is a lot of patients that we have to care for, and that's not going anywhere anytime soon. I mean, maybe GLP-1 medicines will actually help curb some of the things that we're going to see with diabetic retinopathy, but the aging population is just going to grow and grow and grow. And there's no GLP-1 for aging. People are just going to get older, and we're going to see more and more macular degeneration and have to take care of more of these patients. And we know that increasing aging increases that risk of age-related macular degeneration. We see neovascular AMD in patients that are a little bit younger and geographic atrophy in patients who are older. Joe, you've been in this as long as I have. How have you seen your practice change over the last 15 years in the patients who have age-related macular degeneration and the flow of your practice?
Well, I'm hoping that we'll get into this later. But it's actually, although it's very challenging, it's not as challenging for some patients because of the second generation of biologics that we have. I think the big thing now is trying to increase adherency to the therapies. I think that induction phase is really, really critical. And we're also seeing a number of patients who would like to start therapies for the non-exudative macular degeneration, the geographic atrophy. These are other individuals, and that takes a little more chair time. And so I think that's where that's where the bottlenecks kind of come in for our patients. And clearly you have to monitor these patients, a little more closely for the conversion of neovascular AMD. And so that I think has caused us to sit back a little bit and understand the flow a little better. We have changed every room in our office now that can be an injection room. We used to have injection only rooms. I do also more direct injections now than I've ever done before to try to handle that load. But in terms of the neovascular component, I think we've been doing this now for almost 2 decades now. And so we kind of understand how that flow goes, but you still have an issue with those individuals that have a high burden, those individuals that need to come in every 4, 6, 8 weeks for injections. And so it's really good to see individuals going out 14, 16, 20 weeks with some of our newer therapies.
Yeah, one of the real problems that we've had in the past, and the newer therapies are doing a much better job of injecting this, is that we really don't match the results that we see in the clinical studies in real world treatment. In fact, if we're talking about retention of vision, in the clinical studies, we use especially Anchor and Marina, View 1 and View 2, we had a high bar for maintenance of vision, which is losing less than 3 lines of vision. Now, that doesn't sound like maintenance of vision. I mean, you think about maintenance of vision of maintaining the vision that you've got, but that was the definition actually, was losing less than 3 lines of vision established with PDT. And in the clinical studies, it was well over 90% of patients maintain their vision in the anti-VEGF studies. In the real world, we're seeing that it's only about 50% of patients with those first generation treatments. And a lot of this has to do with barriers to care. You mentioned some of them. There's the financial burden, there's the burden on the caregivers, there's the time commitment for patients, there's travel costs. I mean, not just for the patient, but like you said, there are family members that are bringing them in. There's the anxiety. There's the fact that these patients are older and they're going to a lot of different doctors' visits. Many patients have co-payments, and we're seeing the impact of some of these co-payments more directly as we lose some of the financial assistance for our patients. I mean, it's a landmine out there for patients to be able to just get in and see us. And then there's our appointments. Gosh, you're so busy that I'm sure if a patient misses an appointment, there's difficulty. I know with our practice, there's difficulty in that patient being able to get back in and see their doctor, and they really want to see the same doctor.
Yeah, I agree. And I think we also have to be mindful that we are dealing with an aging population, and they also have more comorbid problems, high blood pressure, heart disease, diabetes, and a lot of these individuals have cognitive problems. They may have dementia, they may not remember their next appointments, or they just forgot, and you know, things just kind of happen. And so these individuals, they actually deal with a lot. I think we need to be aware of that. What we've started doing too for those individuals with dementia, instead of having the patient as a primary contact, I really think it's helpful to have a family member as a primary contact. We've done some outreach programs where we send them not just a phone call, but we also have an actual person, if they don't pick up, actually call them personally. And so that I think means a lot. Sometimes individuals don't want to answer the phone because they are concerned about a robocall or some call that that's a scam call. And so you have to find ways to reach patients in different ways. So we're trying to bridge that gap. I think the hardest thing for patients is sometimes even when you make the right diagnosis and they get the right care, just navigating through the system for these individuals can be a burden. And I think that that's where healthcare providers can be of some help. just to make sure that patients keep their timely appointments.
Another thing that's really easy, but I think we sometimes miss out on is you'll come in and you'll see an older patient in the exam room and they're alone. And I think just asking, hey, do you have anybody here with you? And if they say, yeah, my daughter's out in the waiting room, it's like, can we bring her back? Engaging that family member from the initial visit to show them the OCT and to discuss what the vision loss looks like and the treatment plan. I worry that oftentimes our older patients sometimes forget things, but also I think sometimes they feel like they're a burden on their children. And their children, they're not going to tell them, oh, wait, I need to have these treatments or I'm going to lose vision. They just say, the doctor gave me a shot in my eye and he wants to see me in a month, but it's not that important. And I think you really can engage the family much more if you have them in the room.
John, I absolutely agree with you. I think that first appointment is really critical to set down the expectations. And again, this also goes back to setting expectations with the anti-complement inhibitor drugs as well. And I think patients have to understand that, this is not just a one and done injection. There will be multiple follow-ups, and this is the reason why we want you to follow up. And if you don't follow up, this can happen as well. And so I always come back to the patient. I come back to the primary concern, which is vision. And if we want to maintain your vision, those injections are critically important. You mentioned something earlier about, what we don't see, well, maintaining 90% of the vision in clinical trials, which we don't see oftentimes in the real world. And I think that has to do with adherency. In the clinical trials, these individuals or the trial is really designed to make sure that patients keep their follow-ups. We make sure that they provide transportation. We make sure that the patient is whole. We address a lot of the social barriers that patients may have. But in the real world, it's very hard to keep those appointments. We know in the real world, they're getting less injections than what they normally receive in the clinical trial. And oftentimes, the people we see in the real world may not even qualify for the trials. Their disease process may be much more advanced. We know that those individuals that live further away from clinics, particularly more than 20 minutes or 20 miles, they really have a hard time. If they come from a socioeconomic stress environment, they tend to not seek therapy as soon as those individuals that may be from a higher socioeconomic status. And so, even if you look in the rural areas, those health qualified programs, less than 70% of those offices have an eye lane. And so those individuals have a high burden, they have a high transportation issue. And so it's really important for us to have outreach programs that can, again, limit that burden and reach those patients earlier so they can come in and let them understand the importance of continuing with those injections.
It's shocking to me to see studies that show that there's such a high rate of non-adherence to treatment for retinal disease. If you look at systematic reviews, almost 20 to 30% of patients are non-adherent to their retinal treatments. Now, we're not talking about a patient who's on blood pressure medicines that really aren't maybe going to tell the difference if their blood pressure is 160 over 110 versus 140 over, 85. These are patients with blinding conditions. And yet we still are losing up to a third of these patients to non-adherence. It's unbelievable.
Absolutely. And I think the hardest part about this, and we see these patients all the day, all the time, and I think COVID was actually a big testament to this. Each time someone misses an appointment, if they go more than a couple of weeks or a month, they could have irreparable damage. We often see people, they definitely respond to the medications. Oftentimes, you see fluctuations in the disease process. We get better control anatomically, but the vision seems to either lag or don't come back sometimes back up to the baseline.
If we look at studies like the IRIS registry, which is an amazing registry, tons of data there, patients with wet AMD that were getting intravitreal injections, over 10% lost to follow-up, 14% with no follow-up within the last 6 months. And interestingly, that number doubles in urban practices and in the African American community. Joe, you take care of a lot of African American patients. Where is the barrier here?
So most time, this is a barrier when we talk about diabetes. In AMD, it only affects about 4% of Blacks. So the majority of my Black patients are coming in for other problems. But I think this is true for any geographically depressed area. I think that they all have the exact same problems. They all have the same social barriers, the same social terms of health, and the deprivations, whether it's transportation, whether it's health literacy, whether it's access to care or maybe being able to pay for care. These are things that we normally see in those communities. And that's what I mean by understanding their journey. For me, I'm more sensitive to it because I'm from that background. This is the hat I often wear, and I really became much more again attuned to this during COVID, understanding why people delayed their therapy when our doors are still open. Um, and so I think it's up to us again to help bridge that gap. I mean, the one thing we have in ophthalmology is photography. Our ancillary test is great. We can show individuals their eyes. We can show them that these are hemorrhages and exudates and cotton wool spots and swelling. There's all these great things that I think is really important for patients to understand what's going on, but it's also equally as important for them for adherency to make sure they have that buy-in to show them when they're doing well. Mrs. Johnson, this is where you started and this is where you are now. And I think that is one way that they're eager to keep those appointments because they see the progress that they're making.
When we miss treatments, when our patients miss treatments, we know that they can have vision loss that's not recoverable, even though we can improve their OCTs. Greenlee and colleagues did a study on lapses of care and wet macular degeneration where they looked at patients that went 3 months or more without a treatment. And certainly these patients had worsening visual acuity, worsening OCTs. And what they showed is over the ensuing year after they were lost to follow-up temporarily, once again, only about 3 months or a little more, they could improve their OCTs, but the visual acuity never approximated the patients who had no lapses in care. And in fact, it stayed pretty much right at baseline. And so even one lapse of 3 or more months in follow-up can lead to irreversible vision loss.
Yeah, and I think this echoes a lot of things that we've seen in our trials as well. Early on, when we looked at the first generation of biologics, it was always against a sham, and those individuals always, all did well. But even in Anchor Marina, in the arm that received PDT, those eyes never really improved much, and delaying therapy definitely caused permanent loss. It caused the photoreceptors to be, just damaged. We see this unfortunately also with diabetes. If you look at Ride and Rise, those eyes that were randomized to the sham arm, once they were switched over to receive therapy, the OCTs improved, but they still did not gain as much vision. And so I really think it's really more important for this particular disease because just a couple of weeks and definitely a month can mean a difference between driving and not driving.
Absolutely. And we see this in a lot of different studies, CAT, Harbor, Anchor, Marina, TAP studies. We see that the sooner you can start treating patients, the smaller lesions, the better initial best corrected visual acuity, the better these patients are going to do. And even the CAT study stratified and showed that patients could all gain visual acuity with anti-VEGF therapy, but the ones who started better, we're talking like better than 20/40, they had a much higher likelihood of ending up with good visual acuity, 20/30 or better visual acuity than those patients that started at 2200. They may gain more overall visual acuity because they don't have that ceiling effect that the patients with good visual acuity have, but they're going to end up about 2125, best case scenario. So catching those lesions earlier and treating those patients more aggressively when they have activity is really important.
And the last part of that too is that once someone's lost an eye, I think they're much more aware of the contralateral eye. I think it's really important for you to bridge that gap again and let patients know because you've gone wet in one eye, you have about a 10% risk of developing wet disease in the other eye. And so this is the reason why I'm going to follow you. This is the reason why we want to keep those appointments.
And you mentioned the irreversible vision loss when we didn't treat these patients. I can remember prior to anti-VEGF therapy, because I came out of medical school in '99 and started my residency. So that was just before anti-VEGF. And you would see patients that had these horrible scars in the back of their eyes. And the old adage was, if you want to see how a patient's going to do when they develop wet AMD in their second eye, look at their first eye. And you'd see so many people that would have a big scar, count fingers vision, and you'd see that classic hemorrhage in the macular area, and you'd think, man, this is going to end up being a patient who's legally blind. And thanks to anti-VEGF therapy, we don't have to have that anymore. And studies like the Marina study really demonstrated for the first time ever, anti-VEGF therapy could improve visual acuity. Whereas the standard of care, we just saw patients lose vision. And in the Marina, these were occult lesions. They tended to be slower growing lesions, perhaps less significant vision loss, at least less rapid vision loss than we saw with the classic lesions. But even at a year, these patients were losing 2 lines of visual acuity and upwards of 3 lines of visual acuity at 2 years. With anti-VEGF, they were actually now gaining visual acuity. It's one of the rare studies that actually showed almost a logarithmic improvement in outcomes compared to the sham control.
Yeah, this really revolutionized the way that, we treat patients.
Yet still, Joe, we see that patients are being undertreated. A great study by Frank Holtz and colleagues looked, and it was published in 2020 at the real world management of wet AMD patients in the first year. And they showed that the majority of patients received 5 or fewer injections in that first year, that critical year. Why do we still not get this, Joe?
I don't know if I think we do get it. I think it's complicated. I think most physicians at this point understand that that first year is critical, pretty much in all our diseases, personally, because you have to really modify the disease. I think the problem is that having patients come in on an every 4 6 week basis, with our first generation of therapy, I think was really tough. It's really hard for anyone to miss work. Just think about your own colleagues. You have your own technicians. If they have diabetes or AMD, they have to leave every month for an injection in their eye. They have to get someone to cover them for 2 or 3 hours. It's a lot. This is again an aging population. It's a very tough for this individual for these patients to come in so often, and the working population is very difficult for them to miss work. So I think part of it just has to do with the patient itself.
Yeah, and we see this correlation in outcomes and visual acuity. It's not just seeing that patients aren't getting the kind of treatments that they got in the clinical studies, but it's actually seeing change in visual acuity associated with the increasing frequency of treatment. Tom Chula in just 2019 published a great analysis that looked at the number of treatments the patients get in the first year and showed really that break-even point being 7 treatments. And if you really get above 9 or 10 treatments in that first year, you're going to achieve improvements in visual acuity rather consistently. And if we look just at a scatter plot, looking at the number of injections and the OCT thickness, the more injections you get, the drier your retina is going to be. And I think that really sets up a great story for the second half of this talk, which is how we can achieve these same kind of outcomes, but decrease that burden of treatment for our patients. So, Joe, before we hear about the next generation of therapies, the changing landscape of exudative age-related macular degeneration, let's go back to Melissa and Anne, and let's hear about the impact of that patient-doctor relationship.
A lot of people don't realize, you could lose a limb, you could lose an arm or leg in that limb, but to lose an eye, that is devastating to me. I don't think I could stand to go blind.
After the first drug that we only used that for a few months, and then in 2022 we switched to another drug and used that for, gosh, I don't know, maybe a year or so, and then we switched to another newer drug.
We tried different medications, but the medication I'm on now seems to work the best. It's actually improving my vision as I can notice it real clearer.
We're just trying to be consistent and persistent with the treatments, and hopefully someday I'll have a little progress.
For what it's worth, I have no choices. You either go blind or you get a shot every month. You live with that.
would love not to have the injections at all, and would love not to have macular degeneration. But uh, as things are, I'm satisfied with my treatment. Yes.
I want to, as long as I can and I can drive, I will go and get the shots so I can see and not lose my eyesight.
I think it's helpful if the doctor can more or less speak to you once in a while, and maybe not at length because I know they're very busy. I know people who say sometimes their doctor doesn't really explain, why there's a change or something like that. So I would say definitely always at least a brief explanation about why there might be a change, any kind of information about well, what to expect.
As I said, I'm 65 years old and I've wore glasses all my life. And the doctor that I'm seeing for the shots is one of the best to me in the world. Is what I've done research on him. He is outstanding. I hope everybody can find somebody that they can get this bond with and trust an eye doctor, because it's very critical to catch it in early stages, and mine apparently wasn't. I was over 3/4 of the way blind in my right eye, but now I have about 65 to 70% of my eye back.
Wow, Joe, that was really insightful. It's heartwarming to hear from Melissa just about how much she trusts me. We don't have those conversations, but you kind of feel like it's there. And Anne clearly, really emphasizes the importance of communication with the doctor and taking time. What are some things that you do to help build trust with patients?
I think the positive reassurance that they're doing well, that they're doing better, that even if they're maintaining vision, and I do let them know that not everyone would get better. So the first goal is to try to stabilize them, and then we'll see how much vision gain we actually get. So, but showing them, the OCT and the photographs on those follow-up appointments, I think is probably the best way I build a strong, equitable re, rapport with my patients.
So, Joe, how do we're busy. You can see how much it matters to Melissa and Ann to have time to talk to the patient. But I know you're the same way. With just if a patient needs to be seen, you're going to see them, and the clinic gets busy, and you get behind. And getting behind really stresses me. How do you manage that personally?
I think it's really important for you to make sure that all your patients feel that all their questions are answered. And so there will be times, there will be patients, particularly, surgical patients, for example, you have to sit back and you let them talk and you listen. Sometimes I will sit right next to them or I put my hand on their shoulder. I mean, it's a little way that I show compassion. And so we have those conversations. Oftentimes, these conversations are very difficult. Most times is when they're losing more vision, which unfortunately sometimes that happens. Whether you're treating someone and you're not getting the outcomes you want, and they may have legitimate concerns, or doc, do I really need to continue this injection, particularly if I have another good eye? And so those take a little time. And also, what I do is that once we're done, we answer those questions. Um, I often dictate a letter to the referring physician, letting them know if there's a change or why I want to stop, Mrs. Johnson's, therapy. And I will also let them know you're going to get a love letter from me. The letter I just sent to your doctor, you also going to get as well. In case the doctor doesn't get it, you can hand it to them, or you can also show this to your family members. And so these are just extra touch points that I do to let them know that I am listening, that I am concerned. I'm trying to be as compassionate as I can in this very difficult time, and they're doing this very frustrating time for them. And John, this is a great segue to the next segment of our discussion. That burden of therapy, and when patients are not getting hitting those targets. And so sometimes I set up targets for a patient where I think that once they're stable, I'm able to extend them out to a certain interval. And so typically I do a treat and extend. And when a patient has recurrent fluid, then we have to make a decision. Either do we decrease the interval or do we even change to a different drug? And so this is where I think where the second generation biologics have really, really are really helpful. The first generation of the FDA approved, and even really the off-label treatments that we have for neovascular AMD, they really targeted VEGF inhibition. They did really great for what they for what they were able to achieve. But again, there was a very high burden of therapy for those individuals to maintain the number of injections that you recently spoke about. In the second generation, I think that what we're doing now is that we're trying to find drugs that are more durable. And this, we have to manage those side effects now with these more durable drugs. But I think, when I look back and I talk to patients, the patients that have the most difficult time are those individuals that are coming in every 6 to 8 weeks. But my patients that are coming in every 12, 14, 16 weeks, that doesn't seem to be a big burden for them. It's pretty acceptable for them to come in, 3 to 4 times a year for their maintenance therapy. And so I've tried to extend those patients out as much as I can. In the second generation of therapy, we have three great medications that are on the market. We're all familiar with aflibercept 2 milligrams. Well, now we have the HD aflibercept, which is also known as the high dose. And with the high dose medication, with the higher molar concentration, oftentimes these people can extend out their treatment intervals. We also have faricimab. Faricimab is the first bispecific molecule that not just targets VEGF, but also Ang2. So it gives you that extra suppression of another molecule that may cause leakage in the eye. And then recently we have the port delivery system. And although this is a surgical system that goes into the eye, it delivers high dose ranibizumab in the eye that can give chronic suppression over time. What are your thoughts about before we get into the trials? What have been your thoughts so far about these agents as we try to change the frontier of the burden in therapy in these patients?
I think for our patients, Joe, it gives them hope. Always having something that you can tell the patient that is progressing and being worked on. I can remember when we had our first generation molecules like aflibercept 2 milligrams and ranibizumab and bevacizumab. As patients struggled sometimes to get extended out, I was able to talk to them about faricimab. Oh, this is going to be coming in the next, year, and the phase 3 study looked really good, and it should be approved in the next 6 months. And then the port delivery was something I love to talk about with patients because we were in the studies and we could see the dramatic impact that was having on our patients. And then for those patients later on, aflibercept 8 milligrams and being able to say this is coming. Especially for our patients now with vein occlusions, which you are going to talk about in another series, being able to give them something constantly to know that progress is being made, I think gives them a lot of hope.
And John, not just hope, but also hope in you because you are the one that's been involved in those clinical trials. I do let patients know that our group is part of clinical trials. I do give them updates in what we have. Obviously, when things are not approved, they're still following the literature just like I am. I let them know, we're hoping to get this new approval in the next couple of months. I want to keep you right here and then hopefully extend you when this next medicine is approved. And then I think it's also important not to oversell it. I think that's a problem that a lot of us got into is that with these newer biologic drugs, because we were able to extend them out longer, everyone may not have been to extend out, 14, 16 weeks that we've seen in trials. But I found that even if you extend patients out an extra 2 or 4 weeks in a chronic eye that's been getting in treatments for over, 2, 3, 4 years, that little small interval means a lot to a patient. They really understand that they're getting the best medication, they're getting the newest medication, and that you as a physician are doing everything you possibly can to make sure that they're getting the best treatment as possible. When I first saw the results from Tenaya and Lucerne, which was a 2-year phase 3 trial for neovascular AMD, and these patients were all naive, those results was really, really, um, it really was a nice thing to see because I thought that for the first time we had something that felt safe that I can extend patients out. This trial was really set up to compare. It was a non-inferiority study between faricimab 6 milligrams to aflibercept 2 milligrams. And it was standard dosing in aflibercept like we see in regular trials. They received 3 injections followed by every 8 weeks for over 2 years. The primary endpoint was actually 1 year. And this was compared to faricimab 6 milligram. Those individuals had a loading dose of 4 And then after that loading dose, they have something called a disease assessment. And if they met certain pre-specified criteria, they were able to extend up to 12 and 16 weeks. And they could go down if they had any problems. But for the most part, we were trying to see if less injections with the faricimab was not inferior to aflibercept. And what they found is that with less injections of faricimab, they received very similar vision gains from baseline. And so this study met its primary endpoint. When you saw the results of Tenaya and Lucerne, what was your thoughts and what was your hopes for your patients?
So, Joe, I think the first thing that really struck me with the Tenai and Lucerne studies was the first study where we actually were reactive to how the patient responded to their first couple of treatments, their first series of treatments. And so you were able to adjust the interval based on how the patient was responding. It was very, not quite a treat and extend, but very much a reactive type of treatment, which I thought was so unique. As far as the results are concerned, what really stood out to me was the fact that the patients had the same level of visual acuity, but with fewer treatments. And we know that upwards of 80% of patients in the first year and the second year were able to maintain 3 or more months of interval between their doses. So you had almost 50% of patients maintain the first year maintaining a Q4 month dosing, and that increased to 60+% of patients in that second year that were on a Q16 week dosing. And so this was really the first time that we were able to see a intravitreal injection achieve these kinds of durability. And that was really pretty shocking. Now, I got to ask you, Joe, does it live up to that in the real world?
Well, John, I would tell you that I think it's important for me to stratify that question on whether I'm talking about a treatment naive patient or a treatment experienced eye, because I do think that there's a difference between the two. Oftentimes when we have these new drugs approved, we tend to put them in our most difficult patients, and we typically may not see the results that you want to see in trials. In those eyes, I may have been able to extend them out an extra 2 to 4 weeks, but clearly, if they were getting injections every 8 weeks, they're not going to 14 and 16. And so I learned pretty quickly that was important. I also found out that you need time for that ANG2 part to actually work a little bit. And so what I would typically do is find out where they would reoccur, bag them down a couple of weeks, load them at that level. So I didn't go back and load them, every month. I load them where the fluid will actually return and then try to re-extend. And I think that in some cases allow people to extend longer once that ANG2 blocker was able to actually have a much more effect. Now, in those eyes that were treatment naive, my results were very similar to what we saw in clinical trials. And early on, I was very nervous about extending patients out even by an extra month. But if those patients had a good response after the first 3 injections or after the first 4 injections, I extended those individuals at a month at a time and see how far I can go. And surprisingly, over 80% of those eyes were able to extend past the 12-week interval without any recurrent fluid. Do you treat the naive patients any different than you treat your treatment experienced eyes?
I do, because of the same thing that you said, Joe. You really do see these improved durability results in the naive patients, and just like we saw earlier and talked about earlier, smaller lesions, lesions with better visual acuity, they seem to respond better.
So, in addition to the efficacy that we saw in Tenaya Lucerne, I was really happy to see that I did not see any significant increased inflammatory events or adverse events that was not comparable. That we didn't see before with the aflibercept 2 mg. They were pretty much equal. I know in the past when we tried to look at biologics that went longer, there was always this black box of being more concerned with inflammation. I was also really impressed with the pulsar data, which led to the approval of aflibercept HD for neovascular AMD. Now, this is a multi-center randomized double-masked study which looked at individuals that had naive neovascular membranes, and they were enrolled into either receiving the high dose of aflibercept every 12 to 16 weeks after loading dose, compared to the 2 mg aflibercept every 8 weeks. And this I actually was very surprised with as well. It was set up as a non-inferiority study. The study met its primary endpoint. Those individuals that were enrolled in the aflibercept HD, whether it was 12 or 16 weeks, had very similar vision gains at both 1 and 2 years with less injections. Were you surprised about this?
I was surprised to see that it actually works so well. And I had to eat a little bit of crow there to basically say, wow, this works. And I really wish we would have been in these clinical trials because we see consistent 3 to 4 month dosing after the initial 3 loading doses. And the real difference in design here is it wasn't a reactive study. The patients were put into that either 3 month dosing or 4 month dosing with the 8 milligrams of aflibercept at the inception of the study. So there's some advantages to that and some disadvantages to that. It's not as reactive, but I think it was still a great study that proved what we see clinically, which is the aflibercept 8 milligrams actually does give us greater durability over 2 milligrams.
Absolutely. And wasn't just seen in the visual acuity, but also seen on the OCT with less injections. The aflibercept HD has similar OCT findings at both 1 year and 2 years. What I was also surprised about is that 77% of eyes that was also an extension trial after their first year. And they looked at it at week 60 and also at week 96. At week 60, they found that 77% of eyes were already receiving injections more than 16 weeks. And by 96 weeks, nearly 80% of eyes were receiving injections more than 16 weeks, and 53% of those eyes more than 20 weeks. Any patients you think may be more suited for one drug versus the other?
I think we have really good data from Tenai and Lucerne to show that patients that have pigment epithelial detachments have a really great response to faricimab. And so when I see a patient with a PED, especially a PED that hasn't responded to other agents, I'll often try to get them over to faricimab because I feel like there is a data to support that. For patients that I see that are treatment naive, I love to do an abbreviated and rapid treat and extend. So with 8 milligrams. So if I see a brand new patient with new onset wet AMD, I'll give them their first aflibercept 8 milligrams. I'll bring them back in a month, and if they're dry, I'll treat them again, and then I'll go immediately out to 2 months. If you look at the half-life data, we know aflibercept's half-life tends to be 9 to 11 days. Half-life can vary depending on patients. And by giving them 8 milligrams of aflibercept, you're adding 2 additional half-lives. So that's going to roughly get you about 20 days longer. And there's some evidence that shows that actually you might have a 34% increase on top of that half-life. So the way I figure it, for a patient that has a pretty normal metabolism of aflibercept in the eye, you're going to get that patient out an additional month. So if I have a patient that is stable on 2 milligrams at 8 weeks but can't go 10, I'll switch them over to 8 milligrams, and I'll usually try to go 11 or 12 weeks and see if I can't immediately extend that stable patient.
Absolutely. So one of the limitations that we do have are those individuals that are not able to extend out, after the loading those 8 weeks plus or minus 1 week. And so I do find that faricimab may give me a little more flexible dosing in those individuals that may be at a more higher touch point. I really want to turn my attention to Archway. This Archway trial was a multi-center randomized double mask study for patients who were treatment experienced. They had to have at least 2 anti-VEGF injections, but no more than 5. There was a surgical implant of a port delivery system of this high dose ranibizumab, 100 milligrams, and this was designed to be refilled every 6 months. And this was pretty much a 2 year study. So it was a surgical implant with pretty much 2 refills. And what they found in this trial is that at the end of the 96 weeks, the visual acuity was very similar to monthly ranibizumab. So this is also not inferior. This was not inferior to monthly injections. So the study met its primary endpoint and had very stable visual acuity. Can you talk about your experience with the patients that you have placed in the port delivery system?
Yeah, Joe. So we've done several post-launch, but we did a lot in the Archway study. We were in the latter study like your practice was. And the thing I will say is that these are the happiest patients that you will ever take care of, particularly the patients that are now in clinic and getting a lot of injections. That actually, someone who's required frequent injections for years and years, to be able to go 6 months without receiving injections is just life-changing for them, and they have a real appreciation for this. And like I said, they are just ecstatic. I actually think, and I didn't believe this at first, but I now have come to believe that the port delivery system is the perfect treatment for our frequent flyers. We used to think that our frequent flyers are patients who had very active disease, and they do have active disease, but the reason that they have disease activity is not because their blood vessels are more aggressive, but it's because their eye metabolizes the anti-VEGF much more rapidly. It eliminates the anti-VEGF, and that's why we see patients who have had vitrectomy requiring more frequent injections and whatnot. And it seems like the port delivery system allows just a constant daily dose of ranibizumab to be delivered to the back of the eye that's therapeutic. And in my patients who I've treated with the port delivery system who have been frequent flyers, it's actually been able to maintain them out to the 6-month interval. And I've not had to rescue more than just a handful of times these patients.
The most important thing that I learned from this trial is that almost 95% of individuals did not need a supplemental therapy before their refill. And I thought that was really impressive. We did know from the latter trial that some patients are able to go longer. And so this was a great safety net. I think that we can feel comfortable that patients are having a consistent sustained dose of anti-VEGF, that their vision and their OCT did not show much fluctuations during that 6-month period. Now, I do remember during the trial, there were some issues. And, I think some things have been modified and you can talk to the modification. But during the trial, there was an increased risk of vitreous hemorrhages. Obviously, that can impair people's vision depending on how bad the hemorrhage is. Sometimes you may need surgery with that. There was also a higher risk of endophthalmitis in those patients, I think 1.6%. And we learn now that, that was from, retraction of the conjunctiva and tenons or just exposure. What has changed since post marketing to decrease um, uh, those things that can happen during surgery?
We were getting updates constantly throughout the clinical trial about new techniques and new ways to do things. They monitored the surgeries like crazy. For the vitreous hemorrhaging, we laser the choroid now. That was something we didn't do early on in the surgery or in the procedure. It dramatically reduced the amount of vitreous hemorrhaging that we had in those cases. And the biggest risk, the concern, and the reason it had a label warning on it was the risk of endophthalmitis. And that was due to conjunctival retraction and erosion. And they really emphasized proper technique for opening and closing conjunctiva, making sure that it's a 2-layer closure with tenons and conjunctiva. And you look, after they modified the technique for the last time in 2020, the risk of endophthalmitis decreased to around 1%. And if you amateurize actually the risk of intravitreal injection related endophthalmitis, if you have a patient that's getting 8 to 10 injections a year, their break-even point for endophthalmitis from either an injection or from the surgery is around 2.5 to 3.5 years, to where your risk is equal between the two. And so when you talk to a patient that's getting frequent injections and they worry about infection, you can say, the biggest risk you have right now for getting infection is how many injections you're going to have. If you get this implant, sure, you might have a little bit higher risk of endophthalmitis early on related to surgery and potential exposure. But after 3 years of shots, that risk is equal between the groups. And that's something I use to talk to my patients about this, and it really reassures the patients.
John, I think you really hit the nail on the head there. My biggest concern, or I see more people losing vision from being undertreated than actually endophthalmitis. I think those risks are real small. I do think, it is a surgery, so you have to be aware of these things. These are older patients, but I think patient selection is actually is also critical as well. You have to make sure they have a healthy, tenons and conjunctiva. I don't think individuals that have blebs are probably, good patients, or those that have maybe ocular surface disease that may put you at risk for infection. I think that for us, now we have to pay attention to the health of the conjunctiva. But I do agree that the aggregate risk of having 8 to 10 injections kind of normalizes over that time point. I'm not quite sure that has resonated with our colleagues because they look at the whole number as a whole. But I think that this is I think if people understand this, that they understand the burden of patients, they understand the anxiety, the problems and actually coming in, real life happens. There is a hurricane that's going on, right now that just hit, Jamaica and now Cuba. If those individuals were getting treatment, they may not get treated for another couple of months. If they had the poor delivery system in, they can probably go a little bit longer and not have the fluctuations that you see when there's a natural disaster or a catastrophe. You know, I know that you were also part of the extension trial, um, the Portal study, and when we retrospectively look at all of our trials, long periods of time, we're talking about 5 years or more from CAT, Horizon, 7 Up, all these individuals, all the vision gains that they had improved, they tend to give up over time. They lose about, 12 to 17 letters over time compared to where they started from their baseline. And we really didn't see this in the Portal study. Can you let me know how your patients are doing on the extension, or are you getting this very similar results where vision may go down just a little, but not as much as we've seen in our other trials?
Yeah, Joe, I feel like we are getting these results, and when you look, the amazing thing is that this is really the first time that we've seen maintenance of vision, where we get those initial gains. And because, as you alluded to, patients aren't being undertreated. When you have a poor delivery system in your eye, you're getting constant daily ranibizumab for 6 months, consistently and therapeutically. And so not having the fluctuations, even the peak and troughs that you can have in patients long term, that are managed well with intravitreal injections. I think that steady state control is really important. And we're seeing these kind of outcomes in our patients that were rolled over into Portal at 5 and now 7 years after having the PDS. And it's amazing too to see, you mentioned it during the 2 years, 95% of patients maintaining that 6 month refill pattern. We see that all the way out to 7 years. Those patients, 95% are still able to go 6 months in between their treatments without needing rescue therapy.
That's amazing. One other concern I had about the port delivery system, in addition to things that can happen during surgery, and it's a long-term monitoring for retraction or exposure of the implant, in AMD was really geographic atrophy. And I think there's some recent data that talks about geographic atrophy if it was impacted or not with continuous treatment. Can you talk about uh, that data with geographic atrophy, if it's something that we are concerned about, or how often should we be monitoring for that?
Yeah, so there was some interim data from the port delivery studies that suggested that the patients with the port delivery system are maybe less likely to develop geographic atrophy. I don't know that we've seen that bear out over the long term, or I haven't seen that data throughout the 5 and 7 years. I will say that when you look at the patients and you see the mean, which is drugged down just a little bit by some patients that lost significant vision in the port delivery system arm, almost entirely was driven by geographic atrophy. So it's not lack of disease control. It's not subretinal hemorrhages that happen in these patients. It's the natural history of GA that causes vision loss. And I know a couple of doctors who actually are looking at patients when they first come in that have GA and wet AMD, and they are recommending that these patients get the port delivery system so that they can focus almost entirely on managing their GA, and they don't have to worry about managing intravitreal injections with anti-VEGF therapy. If you think about it, Joe, if a patient has GA and wet AMD and they're getting treatment for both, they might be coming back to your office every 3 weeks for a shot. If you can put that wet AMD to bed with a PDS, and then you can focus on treating their GA, I think we might be able to have optimized outcomes with better patient compliance, because it's very demanding to go through treatment for both.
And so, John, I want to turn my attention to one last thing, and this is something I'm really, really excited about, and I would love to get your thoughts on it. Our pipeline in ophthalmology is robust. I think we have probably like 80 agents that we're looking at now to try to extend the therapy of our patients. It's really, kind of go around, gene therapy. I'm very excited about TKIs. I'm very excited about RGX 314 and ADVM 022. And all these things have their pros and cons. At least when it comes to RGX-314, this is given in subretinal surgery. It's designed to uh, uh, create biofactories of anti-VEGF injections for chronic suppression. The ADM VM22 is an intravitreal injection. And the tyrosine kinase inhibitor is also an injection. And I think what may limit these is really some of the downsides. What are your thoughts about gene therapy? How should we look at this in context with inflammation? And is there any inflammatory issues you are concerned about that will, if these drugs are approved, that you will be nervous or maybe less likely to use in some of your patients?
Yeah, Joe, I think safety is always an issue. We learned that from the early days of brolucizumab, which was a great drug, incredible drying drug, but did have increased rates of inflammation. That we always have to have an eye towards inflammation, particularly anything that's causing any type of vasculitis. I think that's of paramount importance. From my understanding, most of the treatments, and it is a prolonged steroid course that a lot of these patients have to have, is mainly around anterior segment inflammation and not necessarily vasculitis related inflammation. So I do think keeping an eye towards that. We also know that higher doses of smaller molecules has a tendency to increase the risk of causing inflammatory events in the eye. So I think being mindful of that, but it is really an exciting future as we think about some of these treatments that could be 6-month or 12-month therapies, could be great adjuncts for our anti-VEGF therapies as well. I certainly think for all of these therapies, we're going to dry patients out with anti-VEGFs. So anti-VEGFs aren't going to go away. But then the hope is just you can extend the patient's interval out with these newer treatments. What do you think, Joe?
John, I think we are living this right now. I do think that we have more durability than we had before, and so I'm still very excited about the pipeline of potentially being one and done. Obviously, I have many concerns, whether it's RPE migration from subretinal gene therapy or just inflammatory risk with the higher doses of medications. I think, this will probably dictate on if the medication is used frequently or not. But just to decrease that risk, I think, of multiple injections over time, I think is critical. I think the hard part is going to be managing these patients. There's so many things we don't know about gene therapy. 5, 10, 15 years out, how do we monitor these patients? Will patients even, will patients feel that they are cured and not follow up? Do we have, are we able to incorporate home OCT to really personalize therapy? I think that's really what we're going towards, really customize and personalize in therapy for each individual disease. So I'm pretty excited about it, obviously, but I'm also have my concerns about long-term safety.
It's a very exciting future, but a lot of questions still to be answered. And Joe, you've done an amazing job summarizing the next generation of therapies. Just a few key takeaway points for the listeners. We talked earlier about the barriers to retention of care, how delayed treatment and under treatment can lead to lack of the improvements in visual acuity and maintenance of improvements that we saw in some of the phase 3 clinical studies. We know that patients who have smaller membranes at baseline, who present with better visual acuity, tend to maintain better vision and have greater visual acuity outcomes. And Joe very beautifully covered all of the next generation anti-VEGF options, including 8 milligrams of aflibercept, faricimab, and port delivery with ranibizumab. In the clinical studies, we saw that faricimab led to similar reductions in macular thicknesses of aflibercept 8 milligrams and non-inferior gains in visual acuity, but less treatment burden. We know in the 8 milligram aflibercept trials for neovascular AMD that we had similar anatomical and non-inferior visual acuity gains compared to 2 milligrams given every 8 weeks with less frequent treatment, 80% of patients at Q12 and Q16 weeks in the first year of that trial. And the port delivery system showed non-inferior visual acuity outcomes to Q4 week ranibizumab, similar anatomical outcomes at 2 years with 6 month refills. We now have 5 and even 7 year data from the extension studies showing maintenance of that 95% of patients going without rescue therapy with 6 month refills, with less visual acuity loss over the long term than what we saw in studies like Horizon and the CAT extension study and 7 Up.
But John, it has really been a pleasure. Thanks for the takeaway points. I've really enjoyed my time with you, and I always learn so much with all the discussions that I have with you.
Thank you, Joe. It's great seeing you again, and I look forward to our next thing together.
Dr. Kitchens and Dr. Coney, thank you so much for a wonderful presentation.
Well, thank you very much for having me. And thanks to our patients, Melissa and Ann, for sharing their stories.
Absolutely. I think that it's really important for physicians to really understand these stories. And so understanding their stories and listening to their stories really helps you to be more compassionate physician. So thank you very much.
And thank you all for watching. You can claim your credit by clicking on the Claim Credit button on your console. Also, please be on the lookout for our 30-day survey. Your thoughts and comments are important and help us develop future education. Also, we have our third and final webcast in RVO launching very soon, so please be on the lookout for that as well. Thank you so much, and we'll see you next time.